All right, I guess good afternoon now. Um, like Dr. Young said, my name is Dr. Adams, Trevor Adams. I'm an associate professor in the Department of Anesthesia and Pain Medicine. I've been at Seattle Children's since 2013. And I get to talk about pain in children and adolescents with the syndromes we're talking about this morning: Marfan's syndrome, Loeys-Dietz, and vascular EDS. I have no disclosures. So what I want to talk about today is kind of define what pain is, both acute and chronic pain, and what the differences between those two. Hopefully I can get across how important pain is in our healthcare system. I want to talk about what causes pain in these syndromes, what we think causes pain in these syndromes, the treatment, and I want to leave lots of time for questions. I did this talk a couple of years ago, and I talked too much and didn't leave enough time for questions. So I definitely cut my talk down, and we'll leave lots of time for questions. So as a pain physician, we typically use the International Association for Study of Pain as ways of defining things. The IASP is the acronym. And the IASP defines pain as an unpleasant sensory, let's move this a little bit here, an emotional experience with actual or potential tissue damage, or described in those terms of such damage. So the big thing is pain is not always actual tissue damage. It could be perceived damage. Now, chronic pain is pain that persists longer than, sorry, I'm just messing up here. Pain that persists longer than 3 months, often despite the successful treatment of the condition that initially caused the pain. Now, how important is chronic pain? Now, these numbers are a couple years old, but it was found that chronic pain affects approximately 70 million Americans. So very, very huge problem. It is said the burden is greater than the burden for diabetes, heart disease, and cancer combined. So chronic pain causes major disability, causes major missing from work, from school, and has a high healthcare utilization. Patients with chronic pain will visit the ER, urgent care, and their PCPs and specialists way more than the general population. Now, this is all adult data. It is thought that at least 20% of all children also develop or perceive chronic pain. And this number is probably a little bit low. It's actually higher than that. Common problems for chronic pain in children are similar to adults: headaches, joint pain, and pain from cancer survivors are the three highest in children. Now, we talked about how common chronic pain is in the general population. What about in the syndromes that we're talking about today? I'll say it's much higher. So in this survey of 1,000 patients with Marfan syndrome, it was closer to 60% of patients felt some form of chronic pain. And we see the same thing in Loeys-Dietz and vascular EDS. Again, around 60% of patients with these syndromes feel some sort of chronic pain throughout their life. Now, what causes this pain in these patients? We think some of the major causes are joint hypermobility. And I say that a little carefully in that just because you have hypermobile joints doesn't mean you'll have chronic pain. The scoliosis that's associated with these conditions can also cause chronic pain. Dural ectasia, and one thing that I want to really emphasize today is central sensitization, and I'll explain a little bit more about that later. In terms of joint hypermobility and scoliosis, how does this cause pain? Well, there is damage to muscles, tendons, and ligaments. Can be major damage from subluxations or dislocations, but it could be minor damage just from stretching too far. This often leads to pain-related fear and anxiety. And then patients have the fear for movement, which causes deconditioning, which leads to central sensitization, which I'll explain later. Now, I mentioned that hypermobility does not mean you have pain. If you look at every gymnast, every ballet dancer, every cheer dancer, they are very hypermobile, and the incidence of chronic pain is not higher in this population. I'll talk about why this is when I talk about the treatment of these diseases. I mentioned dural ectasia as a cause for pain in these syndromes. Dural ectasia is just expansion of the dural sac, so the membrane that's surrounding the spinal cord expands and causes low back pain, can cause headaches, can cause proximal leg weakness because of the compression of nerves. But this also leads to pain-related fear and anxiety, the want to not move, causes deconditioning, and leads to central sensitization. Now, what central sensitization is basically the volume being turned up on your pain system. So your pain system is there to protect your body. It's your brain's way of letting you know that something's wrong, and typically, which causes decreased movement and to protect that part of the body. Now, unfortunately, sometimes after the damage is done, the pain continues to be fired and leads to a vicious cycle. So your brain not only perceives pain, but also in pain, your brain can send down signals to decrease pain. And in patients with central sensitization, your brain's ability to do that goes away. So you have no decreased pain signals. And then the pain that your body is feeling is increased. So some of these patients, after a while, even light touch of the skin can cause severe pain. And obviously this is not tissue damage, but it is still real pain, but it's just perceived as much more severe than it should be. This causes a vicious cycle in chronic pain. As I mentioned before, you have decreased function, you can have mood changes, which affects pain, sleep disturbance. Sleep is really important in development of chronic pain. And kind of in a cyclic, kind of get in this really bad cycle where pain causes anxiety, that damage is being done to your body when there's actually not damage being done potentially. The brain becomes more focused on the pain. And this causes changes in the nervous system where you have the central sensitization, you have the increased pain signals despite no tissue damage, which causes more pain because there's more anxiety and less movement. And it just kind of goes around and around where, like I mentioned before, we have patients with just light touch of the skin can cause severe pain. And now, if you want to read just one paper about central sensitization, I really highly recommend this kind of older paper now, 2011, by Dr. Clifford Wolf. Really does a good job of explaining central sensitization development of such and the treatment. So we kind of talked about how important chronic pain is, what we think causes chronic pain in these conditions. I want to talk about treatment now of chronic pain, but I want to first talk about kind of the paucity of pain clinics we have to treat chronic pain in children. So this is a map of all the pediatric chronic pain clinics in the US. There are 36, and you notice in the Pacific Northwest, we really kind of don't have a lot. And if, as an example, or as a comparison, if you look at the adult pain clinics, just in Seattle, I looked this morning, and there are at least 10 just in Seattle, and we have 36 chronic pain pediatric in the whole country, as opposed to 10 adult pain clinics in Seattle. Our pain clinic here at Seattle Children's includes 4 pain physicians. Now, this is a little bit misleading because, yes, there are 4 of us, but we all do other things. So I'm an anesthesiologist 4 days a week. I only do 1 day of chronic pain. The other physicians, one has the joint practice in palliative care, and she only does 2 days a week of chronic pain. And the remaining 2 physicians are really big into research, chronic pain research, and they only do one day of chronic pain. So we basically only have 1 full-time pain physician, and we're always trying to hire. It's just there's not many. We have 1 pain nurse practitioner. We have 2 pain nurses. 3 pain psychologists, and multiple occupational and physical therapy providers with expertise in pain. And we also have 2 acupuncturists in our clinic. We have clinics on the main campus in Bellevue, and maybe Everett. We were going to Everett pre-pandemic, but we have not been back since. When you come to a chronic pain clinic at Seattle Children's, it's a long visit. We know chronic pain is very complex. We mentioned all the things kind of affect chronic pain. It's a 5-hour visit, and you meet with a physician, you meet with a pain psychologist, a physical therapist, and you get feedback that day about a treatment plan. We definitely use a multidisciplinary approach to pain management, and that's no different for the pain management in Marfan's, Louise Dietz, and vascular EDS. The treatment is definitely a multidisciplinary approach, and the focus is maintaining and improving function to reduce the development of central sensitization. I purposely did not list any specific medications. The data and evidence and what we see, there is not a specific medicine. There's not a magic pill, unfortunately, to treat pain in these conditions, really in any chronic pain condition. but there's not like a staple for a chronic pain medication. And we really kind of de-emphasized the medications in treatment of these syndromes. We do really emphasize cognitive behavioral therapy with our pain psychologist to develop pain coping skills. There are no side effects from this, and very good data for supporting chronic pain. A really big plug-in for physical and occupational therapy. And I'll just talk more specifically about a couple specific treatment targets. And then complementary medicine, we use acupuncture, massage. Again, no side effects, and we get really, really good results. Specifically with physical therapy, joint stabilization, the ballet dancers and the gymnasts all have very strong muscles around the joints to protect them. And so our physical therapists work on stabilizing those joints by strengthening the muscles. A graded return to function is important, whether physical therapists help patients with, and graded cardiovascular exercise. Exercise has been shown in itself, the increase in heart rate to help reduce chronic pain, and then specifically in these patients, following obviously Dr. Olson's guidelines about what types of exercises you do. So hopefully I was able to kind of explain what causes pain in these syndromes, how we treat it, and how important it is. And I would love to have any questions that you may have.
Wow, you're not kidding. You left a lot of time for questions. That's awesome. Thank you.
Yeah.
Really, really great. Okay, let me look down. These questions are for you. Okay, can dural ectasia affect your head, such as extreme brain fog? And what are the best treatments for dural ectasia? Is that something that you'd be able to address?
Yeah, I don't think the brain fog, dural ectasia would not cause specifically brain fog, but dural ectasia could potentially lead to central sensitization, which there's definitely cognitive effects from central sensitization. So, and as well as deconditioning, poor sleep. So those definitely can be indirectly caused from dural ectasia. Besides, there are surgical treatments, but also focusing on staying conditioned, sleep, and kind of a multidisciplinary approach to pain would be the treatment.
Okay. So here's a question. Somebody has dislocated their shoulders a couple of times, and they just popped back in place. She was sore. She's more sensitive to stretching those areas and afraid of injury. But any idea why that happens? And they do have this person does have hypermobile joints, as you talked about earlier. So if you wanted to say something about that, and I think there's a little note here that Dr. Byers wants to answer this question as well.
Okay, sure.
So you can start.
Why do the joints dislocate? Is that the question, or why?
Yeah, like what, she's sore because the shoulders keep dislocating, and
yes.
so she wants to be able to stretch them. What are the best ways to improve the muscles there? How can she get rid of that pain?
Yeah, I mean, it's definitely a painful thing is to dislocate or sublux. I would say it sounds like joints, and then as mentioned, the most important thing is to not let that stop you from doing it. I think that can potentially cause people to not want to move that joint at all, or very limit, and maybe use braces, use different things, which can actually may help in the short term, but in the long term is going to cause more pain because it's going to lead to central sensitization. It's going to lead to anxiety for movement. So getting into physical therapy would be my number one suggestion to, and specifically for joint stabilization, and learning ways to move so that doesn't happen as often, and also to strengthen the muscles around that joint so that it doesn't happen as often.
Great, thank you. Peter, are you there? Did you want to say something as well? Or maybe
okay. I was actually trying to ask a question, and that's what happened when I tried to do something.
Well, go ahead.
I don't think the chat's open to me.
That's okay. Go ahead. You can ask your question.
Well, one of the things about that Renee had asked about is we try to discourage people from stretching. I mean, most of the people who have very loose or very hypermobile joints really don't need stretching. They need warm up if they're going to exercise and things like that, but stretching is not it. It's one of those things that feels great often, but it's more likely to increase subluxation. And I think, as Trevor was saying, that really it's a matter of building musculature about there. What I was going to ask about is actually with long COVID and things like that, is that bringing much in the way of insights into chronic pain? And I mean, certainly there's the whole aspect of chronic fatigue and things of that, but what about chronic pain?
It's probably, is it bringing insight? No, it's making it more confusing. Yeah, I mean, I think we
Pathways even.
yeah, I mean, we're definitely seeing increase, I think, in chronic pain, and we're seeing central sensitization type syndromes coming from long COVID, but that kind of seem the same in terms of, deconditioning, brain fog, the mechanism why that causes it. Like, there are thoughts that sometimes viral illnesses can trigger this kind of change in your nervous system, but yeah, I think we're going to learn a lot more in the years to come, but right now, not a lot of ideas of what, the reasons why.
Right.
Thanks.
Thank you. Another question here for you, Dr. Adams. What is your opinion on cervical nerve ablations?
Cervical nerve ablations. That sounds pretty permanent and pretty, how would you say this? Severe. I mean, cervical nerve ablations sound kind of scary to me. I know that we don't do that very often in pediatric patients because of long-term effects. Those are important nerves. I would hope that you had tried a lot less invasive things prior to that. It would be my caution, I would say.
Okay.
And I have no experience with those.
We have a very educated patient community here, so you're going to get only hard questions today.
Great. Yeah.
If you were in an area without a pediatric pain clinic or specialist, where would you start looking for assistance?
Probably, I think even though you have a pain clinic, which is very multidisciplinary, you can kind of still piece that together in smaller communities. So in terms of, like, our pain clinic is a pain physician, a psychologist, and a physical therapist, so the three main groups. So you can kind of, there are psychologists throughout the country that maybe not specific have pain expertise, but they do offer some pain psychology, which is super important. In terms of physical therapy, you can find physical therapists just about anywhere, but you need to kind of be kind of specific of what you're looking for. This is not just sports physical therapy for an injury after sports. It's more like specializing in joint stabilization, and most physical therapists, if you say that, can kind of develop a plan for that. And then pain physician, like I said, I don't prescribe a lot of medications for this. You don't specifically need a pain physician, but just somebody to kind of help coordinate the physical therapy and the pain psychology. And we do see patients from all over, and telehealth is great now that we can offer, I think, patients that live kind of far away from these centers care via telehealth.
I'm glad that you mentioned pain psychology, because there's a question about, I'm not sure if it's pain or fear here, advice for getting a child who has extreme fear of phlebotomy, which is stopping getting genetic lab work done. And is that more fear or pain, or is that like your pain psychologist that you're talking about?
Yeah, I mean, pain psychologists help with that, but also Child Life in most places are really, really great with that. I would actually say Child Life would be the best kind of my number one choice to help with that. I know here at Seattle Children's, we have Child Life that will, you can specifically consult them for pain with either coming into the hospital to see a physician. A lot of patients have fear just with that, and then specifically with needles and phlebotomy is even greater. But Child Life is a great resource for that, and almost every pediatric hospital has that that service.
This is Luch. I think lidocaine cream to the area prior to having the blood draw is also quite helpful.
Right. And also,
yeah, go ahead.
And also Peter is saying there are alternatives to blood draws. It, could be saliva as a resource as well. So that's another option.
Good points.
One thing that you mentioned that I just wanted to bring up is, and I think you did it sort of quickly on one of your last slides, talking about function. And pain is something we talk about at a lot of our conferences and symposiums that we have. And so I think people come into, pain specialists wanting to eliminate pain, where really it might be about increasing function, like what do you want to do? And how do you want to get through your day? So can you talk about that a little bit and how people can kind of think about pain in that framework?
For sure. We definitely in our clinic focus on function. We tell patients that what we expect is that your function is going to get better before the pain. And I think patients are often frustrated with that, where we'll see a patient for initial evaluation. We'll come up with a plan that involves physical therapy, greater return of exercise, cognitive behavioral therapy, and then I'll typically see them 2 or 3 months later to see how they're doing. And they'll tell me that they're not missing school anymore. They're going out with their friends again. They are maybe have a job and are kind of doing kind of normal things, but they're upset because their pain has not changed. So they're focused on their pain scores still being 6 out of 10. And I always encourage them, just stick with the program a little longer. For some reason, your nervous system pain is the last thing to get better. And so they're way more functional, they're doing more. And then I'll see them again 2 months later. And the patients that I can convince to just stick with it a little longer, then I'll see them 2 months later and the pain is down to 3. And they're a little more encouraged. And then potentially, 2-3 months after that, then their pain can be completely gone. But we do know that chronic pain is not something that gets fixed in a week, or even, depending on how long you've had chronic pain, it could take months, years to get completely better.
Right. And if your function is getting a little better, then you're on the right track.
Head in the right direction. Yep, for sure.
Well, thank you so much for this. This was really great. We appreciate your time this Saturday, and there's a lot of great information for people. So thank you so much.